Hey guys, Dr. Gary here, double boarded in facial plastic surgery and head and neck surgery, and I do a lot of hair restoration surgery. This is a reaction video to Dr. Gavin Chan. I've been seeing a lot of his videos on YouTube. He has excellent content. He, based on the profile online, is like an emergency medicine doctor who then went into cosmetic medicine and does a lot of injectables and does some liposuction from what I can tell. And he practices in Australia as part of the Victorian Cosmetic Institute. It looks very cool. He has a nice presence online, and I saw this video pop up. I actually have never watched it. It just caught my attention why I stopped filling tear troughs. And the reason why I stopped and did a little double take on that title is because I don't really enjoy filling the tear troughs either. And I know there are a couple of dermatologists who I know personally, and some, plastic surgeons as well here in New York City, who also no longer offer that type of procedure. We'll watch and see why he stopped, but the primary reason is that it's just not very predictable and reliable of a place to inject filler. I can go into some more detail, and I'm sure I will as I watch the commentary that he's making throughout this video. So hopefully you guys enjoy, and please, we have a nice growing channel, but make sure to subscribe and turn on your notifications, because this way you find out about all the upcoming content, and we have a lot in store for you guys. Thanks again for all the support to date, and let's keep growing this thing.
Tear troughs. They're the grooves or hollows just underneath your eyes and are a significant cosmetic concern for many people.
I was born with extremely dark hereditary dark circles.
The thing now is really the under eyes, and it really bothered me because the makeup wasn't hiding it.
So that tear trough, it's basically the lower eyelid as it's about to transition to the cheek. I don't want to take anything away from the video. I'm sure he's going to go into this, but just jumping on the opportunity here, that area starts to experience some changes as we age. So when we're very, very young, there's nice fullness there. There's this smooth transition between the lower lid and the cheek, to the point of not really seeing a separation between those two subunits of the face. As we age, there are certain changes that occur that I'm sure he'll cover, and if not, I'll make sure to add in.
It's no surprise that they are one of the most popular areas on the face to fill with dermal fillers. The idea of a simple, non-surgical procedure to fix what is often a lifelong concern can be alluring for both patients and practitioners. In fact, it took me 14 years of filling tear troughs from 2005 to 2019 before I came to the conclusion that I shouldn't be doing this treatment anymore.
14 years he was doing it. I mean, that's a long time, and we'll see. I wonder if he talks about not just why he stopped filling, but why it took him so long to stop filling. That to me is interesting, because I feel like there's a lot of things that we're taught, and then we go to seminars and people lecture on certain topics, and what I find is that some of that content just doesn't make sense, and it doesn't translate well into high levels of patient satisfaction and safe procedures. So you have to be super critical when going to meetings, when learning new procedures, whether it be surgical or non-surgical. And then when you actually start it in your practice and you start doing these things to people, you have to be super critical of what your results are and how happy your patients are, and pros and cons. And I think any monetary gain has to always be secondary, and the primary thing has to be, is this patient really benefiting from what I'm doing? Am I seeing overall good results? So I'm really curious as to what Dr. Chan has to say about that.
In this video, I wanted to share with you my journey and experience, and provide you with expert opinions from Dr. Mobin Master, radiologist, Mr. Bryan Mendelson, plastic surgeon, and Dr. Burt, ocular plastic surgeon, to provide evidence and shed further light on the topic.
Those are well-known people for sure. Dr. Mendelson wrote a textbook on facelifting and is a prominent figure internationally.
I started filling tear troughs back in 2005. To be honest, the results over 14 years were varied and inconsistent. When I started, I probably didn't know what I was getting myself into. I used to put in large amounts of filler to show a difference and make patients happy at the end of a treatment.
Yeah, when you put in large amounts of filler, you're going to run into problems. And you have to think about what is filler? What is this filler that we're using on people? It's hyaluronic acid. It's something that exists in all of our cells, and it's almost like a sponge, right? It attracts water. That's how it works in the lower lid, right? You're going to put this material in. It's going to, over the course of months, sometimes years, continue to attract water. And yes, it will resorb and absorb within the body to some degree. But as we know from many studies now, it does linger around for a long time, much longer than we all like to admit. And during that time, it's going to keep pulling in water. And as it does that, you're going to get this puffiness that occurs. And the skin of the lower eyelid is super fine. And the lymphatic channels in that area, and those are the channels that drain any kind of swelling, are also very small. And you kind of end up blocking a lot of them up with this filler. Now you're blocking a pathway of swelling drainage, and you have all this material that's accumulating water, and it's going to give you a puffiness, and that's what drives people crazy after lower eyelid filler when too much has been placed.
Tear troughs, one syringe, possibly per side in most cases.
Yeah, so here he has a video of him years back, and he's talking about putting 1 ml per side. That's a lot of filler. I still do lower, lid tear trough filler, not often, but I still will do it on occasion for the right patient, and the numbers are much lower than this. Usually it's going to be about half a syringe between both lower lids. But again, sometimes that number does go up, sometimes it goes down. And I've had patients where you can see obvious improvement and they're still unhappy. They still think that, they need more, and they go to someone else, and then they get overfilled.
And I find, especially with deeper ones, you need the full syringe.
Only to find that my patients will come back later with puffiness and overfilling as the filler hydrated.
Yeah, the hydration is exactly that sponge effect that I was referring to. I mean, it's great that he comes out and admits this. It's not easy to tell people about why you stop doing something. I personally stopped doing buccal fat removal, and I plan on making a video, referencing that and giving you guys a specific set of reasons why it wasn't the right procedure in my practice.
The nature of hyaluronic acid fillers is that they are hydrophillic. That is, they love water and attract many times their weight in water with time.
Then when he did it, I saw an immediate difference, and it was crazy.
You can see instantly how it feels in.
What you see immediately after the injection is not a true result.
He's absolutely right here, and this is why when you're seeing in your Instagram feed these amazing immediate post-operative results from different providers, some are doctors, some are not doctors, all types of people who are posting these results, you have to be just very cautious about, jumping to any conclusions, because you really want to see more long-term results. When we're posting surgical results, we usually are posting many months after surgery, to kind of show people, what it looks like once things are more healed. But with fillers, and after filler injections, you're rarely seeing those results many months later.
The combination of the hydrophilic nature of hyaluronic acid fillers, the fine skin around the eyes that showed any filler imperfection, and patients that wanted perfection,
and the lymphatics being much more fine in that area and not so plentiful and getting affected with the filler is another reason.
A recipe for disaster.
It never really got to a point where I really was satisfied with it. I had to go back a few times to get it sort of evened out. And this side was never looked the way that I wanted it.
And remember, we have videos on this, but faces are asymmetrical. So it's very common for a person to be more content with the results of one side than the other.
I started noticing these really harsh dimples forming underneath my eyes. And I spent the past 3 months going in again and again and again and again and again.
And when patients come back into the office complaining of these different issues with the tear trough area, oftentimes the provider feels the need to just place more, just keep pumping it in there, and that builds up that quantity and it builds up the problems over time. And then when you try to dissolve it, it's very hard to partially dissolve the filler. You kind of have to go all in or do none at all. Micro droplet dissolving isn't a very effective process. It could help sometimes, but generally it's better just to get it all out. That's where it becomes tricky with managing expectations and just managing the area when people are coming in time and time again because they're not happy.
Chasing that elusive, just right tear trough result. I tried filling tear troughs with smaller amounts, using less hydrophilic fillers, and modifying my techniques.
He's right in that there are different types of HA fillers, of course, and some attract a lot more water than others. So for example, I don't like to use anything like Juvederm in that area at all, because it's going to attract about 6 times its weight in water and give you that much fuller look that's going to just look unnatural, and you won't be happy with it. The most common filler used these days for the tear troughs is Restylane L, which is a type of Restylane product. It's sort of a medium grade as far as the viscosity or the density of the filler. There are different types of Restylane fillers. Some are much more liquidy, some are more firm. So this is like middle of the road.
And using the use of cannulas rather than needles.
Yeah, there's always the debate of cannulas versus needles. Needles, you can be a little bit more precise, but the risk of bruising is much higher. My preference for the tear trough is a cannula, but it doesn't mean it's the right way to do it. It just means it's my preferred method.
Complications such as swelling or puffiness of the lower eyelid were still quite common despite these changes. I was always reassured by what we have been told about the longevity of hyaluronic acid fillers, which is that they only last for 6 to 18 months. So any complication should be resolved in that time frame, right? After several years of doing tear trough filler, I started to question this, as we had several cases where swelling or puffiness persisted for many years, well beyond the 6 to 18 months we were told that fillers last. Sometimes the puffiness occurred years after having what appeared to be a good result. Some patients had puffiness from filler for years without even realizing it was the filler, thinking it was just aging kicking in. To see if it was filler or maybe just fat pockets under the eye.
It can be hard to tell sometimes if the swelling that you're seeing is some effect of what's called pseudoherniation of fat from the fat pockets of the lower lid, or is it that you have this filler that still exists in that vicinity?
We started doing MRI scans on those with persistent swelling. Due to the hydrophilic nature of filler, filler signal on MRI is white, similar to the signal for water, and its presence is clearly delineated on MRI. What we found was a real eye-opener. We had many cases where we saw filler lasting from 2 to 12 years on MRI. In this interview, I spoke to Dr. Mobin Master, who performed these MRI scans.
Yeah, I've definitely heard of these studies, and it'll be good to hear from the person who conducted the studies, but filler, whether it's in the tear troughs or anywhere else on the face, is going to linger around for a lot longer than we want to believe. I specifically remember during my training at Washington University Hospital seeing it was a neck lift that we were doing, and when we had raised the skin flap up off of some of the deeper muscles, we saw these deposits of white throughout that skin flap, and it turns out that that patient had a type of filler called calcium hydroxyapatite placed into that region. You guys may have heard of it as radius, and it just kind of like clogged up a lot of the area there and was deposited all throughout this flap, and the vascularity, the amount of blood supply in that flap was definitely diminished because of all these prior injections, probably into some surface lines of radius. So all these injections are not without their problems, and so you have to really think twice before getting these non-surgical procedures. Obviously surgery has risks, but so do non-surgical procedures as well.
Good to see you. Thanks for coming in to share some of your invaluable insights with us.
Yes, good to see you again, Gavin. Always a pleasure.
Thank you, thank you. So this is the man, a radiologist and cosmetic physician. He is a guy I send to when I need to see stuff beneath the skin. So he's like the answer book. He gives us all the answers. And I think there's been some huge insights recently in the past year or two, where we've done some MRI scans of patients, and you've found a lot of interesting things.
Very interesting stuff. As you mentioned on the previous longevity interview that we did together, and that actually kind of changed the face of injectables pretty much. It has really changed the way I inject,
changed my practice too,
the way you practice as well, and many other injectors. So the paper in Plastic and Reconstructive Surgery of America was accepted, and it's currently released, and it's on paperback in January 2021, and it describes 14 patients, and we showed that many patients had filler still there after 2 years.
Yep.
One of them was 12 years, and there was still hyaluronic acid filler in the tear trough or in the orbital area.
Remember also that one of the main predictors of how long filler will last in some part of the face is how much movement there is in that area. So the reason lip filler tends to resorb quicker, it doesn't mean it all goes away, but it starts to resorb quicker, is because of the movement of that area, right? We're always moving our mouths, eating, talking. In other areas such as the nose, such as the tear troughs, those areas don't move and shift as much, and so product tends to linger much longer.
I believe out of that study, out of 10 patients who had fillers more than 2 years ago, all 10 showed?
All the ones that had a
Fillers?
question of do they have filler over 2 years, all of them had filler.
100%.
Yeah.
Isn't that amazing? That's just blowing me
It's a
away.
small...
One might argue that even if fillers do hang around for many years, they are fully reversible with injections of the enzyme hyaluronidase. I used that as my justification for continuing with performing tear trough filler until I had a case of lower eyelid swelling that I just couldn't dissolve. Again, Dr. Mobin Master reveals how this happened. Just over a year ago, I had a patient which I sent to you, and it was a really difficult patient, and she had fillers done in her tear trough, and she had this persistent swelling which just wouldn't go away. And we dissolved it with a bucket load of dissolving or hyaluronidase, and it just wouldn't go away. And I was so puzzled, and I sent it to you. Maybe you can tell us a bit about what we found.
She was a fascinating case actually, and you sent her to me and I thought, well, how are we going to work this out? And you said, well, why don't you do an MR? So we did an MRI and we found that yes, there was filler in the tear trough area, which is, you know, quite typical, and it shows that bright signal on T2, which demonstrates the filler located in the tear trough area. But it also showed post-septal filler, meaning that it was underneath the globe. So it had somehow got under the globe. And since then, we've had another 2 cases of that, and we can discuss the treatment.
That is phenomenal. So maybe you can explain to the viewers maybe what the orbital septum is, and you know what it means to go through that and go underneath the globe, or the eyeball, basically. Just explain, you know, why was this patient so difficult?
So the orbital septum is actually a division beneath the eyelid that separates the globe and the intraocular, or in the eye, the actual eye area underneath your actual eyeball. Mm-hmm. So you've got a septum at the bottom and you've got a septum at the top. And for example, if you've got a really bad infection, we always talk about, has it gone post-septal? Because that's dangerous, because it means it's gone underneath the globe. So it's a barrier. It's basically a very fine film barrier.
I would argue that a lot of injections in the tear troughs actually go post-septal. When people are taught how to inject, one of the primary ways is to inject sort of onto bone. You can inject more superficially, but then you have to worry about what's called the Tyndall effect, where you get this bluish hue that comes through because that filler is just too close to the surface of the skin. So in order to kind of like prevent that, people are injecting deeper, and a lot of times they're feeling for bone. As you feel for that bone, you essentially in some areas are already post-septal as you're putting in, whether it's a needle or a cannula. So I think a lot of filler in general is going post-septal. In this situation, they happened to do an MRI of the patient and saw it there, but obviously we don't have the resources, you know, internationally to just perform MRIs for everybody who's had, you know, lower lid filler. But if you did, my guess is that vast majority of them would demonstrate some degree of post-septal deposition, just based off of how a lot of people are injecting this type of HA filler into the tear troughs.
It's finer than we think.
Mm-hmm. So a needle or cannula could penetrate it pretty easily without knowing.
That's right.
Potentially.
And one of the cases was, I think the case that you had sent me was a cannula, and the other, I think one other case from elsewhere was a cannula and one with a needle.
Okay, there you go. But this MRI that you did explains why we had such a hard time dissolving it. So maybe you can explain, you know, why it was so hard and what was done to actually alleviate that filler.
So clinically, what you do is you get the needle and you inject where the puffiness is, right?
Yep, that's what we do. Yep.
So generally, that's a logical point of call, and you were trying to inject and go, okay, why is this not going away? The septum, though, is underneath the globe, and not in a million years, I don't think an injector would have thought it has gone under the eyeball. And you're probably, without ultrasound vision, you probably wouldn't be willing to stick a needle under the eyeball, would you?
That's why we had problems, because we never stuck the needle under the eyeball. So
That's right.
I left that to my friend here, Moment.
If you use the cannula, there's a way to feather it in a deep plane where your risk of causing a lot of damage is low, but you're still able to get post-septal to dissolve the filler. So we'll see how they approached it here. And also keep in mind that lower lid swelling is not always just HA filler that hasn't gone away. There are also, for example, festoons that exist in that lateral lower lid sort of cheek junction area, and that can occur in people who have never had HA filler. Their lower lid has never seen HA filler. So you could have a situation where someone was already prone to that type of swelling, and then on top of that they also happen to have had HA filler maybe even years prior. So lots of different scenarios here. So, you know, in their case, they're basically chalking it all up to HA filler, but potentially there are other things at play here too.
What I did is I get an ultrasound probe, and you're running a needle underneath the ultrasound probe where you can actually see it. So it has to be directly parallel to that probe, and I could see the globe, and I knew where the filler was, but I couldn't, it was kind of semi-blind, i.e. I couldn't actually see that post-septal filler, but I knew I was directly underneath the globe. So I used the MRI like a map. So it's like a map in front of me. So I was looking at that going, okay, it's under the eyeball, probably dead center. And then what I did is I used the ultrasound to make sure that my needle didn't touch the globe.
Okay.
So I'm within a few millimeters of the actual eyeball.
Wow.
And then squirted it, and then we did an MRI afterwards, which showed that it had resolved, and it got rid of the filler underneath the eyeball.
So, we must have tried about 7 times to dissolve this just without ultrasound guidance or MRI, and it really took your expertise to do this. And I'd imagine that in the world, there are not many people who actually have done this sort of dissolving. I could imagine, you know, you'd be one of the few who...
Yeah, I haven't heard of anyone doing dissolving underneath the globe.
I think people are doing it. They're doing it sometimes without the use of ultrasound guidance. You can do it based on palpation as well. You just have to be knowledgeable about the structures in that area. Personally, at least in New York City here, if I had a complicated case of lower eyelid swelling or any kind of situation that was beyond the ordinary, I have a couple of ocular plastic surgeon colleagues who I send to, and I can tell you that their dissolving does not involve ultrasound guidance. It's based off of knowledge of the anatomy and can still be done via palpation technique.
This first case where we've had this post-septal filler, you've had a few others present?
Yeah, we have had a few others, and while we're talking about that, there's a picture you can see there of the before and after the post-septal filler was dissolved, and you can see a little crease under her eye has come back, meaning that it's less puffy.
Yep.
So we did get, majority of the resolution in that case. Another 2 cases did come to me, and I MR'd these patients. I didn't expect it. And these 2 patients had post-septal. One of them had an injection 12 years ago.
Wow, there you go.
She said she was puffy immediately after the injection, and often this is the problem. You're puffy immediately after the injection, and then you wait for it to resolve, but then it never resolves. So I think it was in the post-septal or underneath the eyeball from the start.
Again, I think that occurs pretty high frequency that just goes undetected most of the time.
And I did exactly the same process, the same pathway.
Given fillers can last a very long time and also have the potential to be injected post-septally or under the eyeball, I needed to make sure that there was an appropriate basis for treating tear troughs with fillers. I started researching this, and I found the answer was right under my nose. I found in 2012, Mr. Bryan Mendelson published an article titled "The Tear Trough Ligament, Anatomical Basis for the Tear Trough Deformity." Unfortunately, the cosmetic world didn't heed the warning contained in this paper that is almost now a decade old. In this paper, through dissection of 24 cadaveric faces, he found a true osteocutaneous ligament attaching skin to bone in the tear trough. That is, The skin of the tear trough groove is tethered to the bone underneath by a ligament, which means you can't lift it with filler. It's anchored down. It's like the buttons of a mattress, pulling the mattress down. You can't lift these buttons by stuffing more foam or padding underneath them. You can see this when you are squinting. The orbicularis
It's called the orbital cutaneous ligament.
oculi muscle that surrounds the eye moves except for the tear trough where it is tethered down to. Many attempts to find an anatomical basis for the tear trough have been made in the past, with no prior studies finding a tear trough ligament. Mendelson states that the discrepancy was from the dissection approach used in previous attempts. Basically, there's been a lot of hypotheses about why there's this hollow trough there, and multiple surgeons or anatomists or doctors have tried to find this a ligament there and been unsuccessful. So maybe you can tell us why, what made your study successful. How did you find it when others had failed?
Well, so often with anatomy, it's the way you dissect. And all surgeons know that. One day you dissect a few millimeters to the side and you see the structures differently from what you're used to seeing. But fundamentally, surgeons dissect by layers, and they lift off the skin, then they lift the orbicularis, and then they go down to the layer 3, where the ligaments may be. And they couldn't see it. And the reason that they couldn't see it is because the ligament extends between the dermis and the bone. And as soon as you take the top layer off, the ligament loses all its structure.
Mendelson's anatomical approach found the elusive tear trough ligament that hadn't been found previously and helped explain the reason why filler simply can't lift the tear trough groove that is held down by this ligament. In his publication, Mendelson's conclusion was that filler can be placed underneath the tear trough ligament to support it, but should not be placed above or directly into the tear trough, as this can aggravate the deformity. Given its tough fibrous nature, I feel that filling directly over or in the tear trough ligament commonly leads to extrusion of filler to either sides of the ligament, which causes puffiness in the lower eyelid. The technique suggested by Mendelson of placing filler underneath the tear trough ligament, essentially in the cheek, has become my go-to method for consistently improving the tear trough groove through support of the ligament. I never fill over the tear trough groove or ligament now. To see if a patient will benefit from this supportive filler, I perform a simple press test on the cheek. If there is improvement in the tear trough from the test, then it is likely that filler in the mid-cheek under the tear trough ligament will help.
So basically he's talking about filling the medial cheek as opposed to filling the tear trough itself. One other concern here, other than just not getting much improvement in the tear trough, is if you overfill the medial cheek, the person starts to look very centrally heavy. And when filling the cheeks in general, you want to emphasize the lateral cheek over the medial cheek so that you kind of restore that kind of heart-shaped appearance as much as you can when it comes to filler. And that's one of the risks of overfilling the medial cheek. So I'm assuming he's not using high quantities of filler in that region, but that definitely is something to watch out for.
It may not completely remove the tear trough groove, only soften it, and that further improvement may require surgical correction. Surgery should also be presented as an option for anyone presenting with concerns about their tear trough to provide a more balanced view, even though the prospect of surgery may be scarier than a few injections.
Yeah, and then the question becomes what kind of surgery to do, and that goes into a whole other discussion. I'll just kind of gloss over it here. I'll probably make another video specifically addressing lower eyelid surgery, but the options are either to do a blepharoplasty from the outside, where you make an incision under, it's called subciliary, right at that lower eyelid margin, or making the incision on the inside of the lower eyelid. That's called transconjunctival approach. And when you do that approach, either approach really, you can get to the fat pockets of the eyelid, and then either you take those fat pockets out if they're puffy, right? If they're causing a puffiness to the lower eyelid, you can remove some of that excess fat pockets. Or if you have fat pockets there, you can transpose, which means that you take those fat pockets, you lift up that ligament that they're talking about. So you're basically taking the muscle off of the bone there, the orbital bone, and you're transposing the fat pockets over that bone, and so you're blunting that more buckled down tear trough cheek junction by transposing the fat over that area. It's a little bit hard to conceptualize, but that's another way to do it. And again, then you're reducing that distinctiveness of those two areas and making it smoother, kind of the way that things used to be, right, before the aging process took hold. And then thirdly, another adjunct procedure that can be used is using fat, like fat transfer to the face, and that's meant to essentially serve as a similar to HA filler, but in the form of fat, which is a lot longer lasting. And what you can do is you can actually transfer also nano fat that has stem cells to help rebuild the area without dumping a lot of volume into the area to cause, you know, potential problems. So it gets a little bit complicated, and we'll need another video to discuss that.
I spoke to Ben Burt, oculoplastic surgeon, about the surgical options for tear troughs.
There we go.
I'd like to introduce Dr. Ben Burt, who is an oculoplastic surgeon, and he is very well known for his work with lower eyelids in particular. Firstly, so what sort of people are you seeing come in for lower eyelid surgery? When would you say it's time to have surgery now?
I think there's two big groups. So there's one group that I would almost say are congenital in terms of their tear trough deformity. And those people always have noticed that feature. Even when you look at photos of them as a child, maybe one of their parents has it as well, usually one does. And they've never liked that appearance, and they've always waited to have something done about it.
So these patients are really quite young. So it's not like necessarily like an older sort of patient. They can come in their 20s, say, for example?
Yes, even teens.
That's definitely a good point. So it's not just the aging process, it's also sometimes the way we're born. And that also goes for example, lip lift surgery, which, as you guys know, I do a lot of. Sometimes the philtrum gets longer just with age, and sometimes we just basically start off with a shape of the lip that we don't like, or just a longer philtrum, just congenitally, we're just born that way. So the same thing goes with some of these orbitocutaneous ligaments in the tear trough area.
Probably once, twice a year, you see someone who is so sure they want surgery, and their parents know about it, they're unhappy about it, and they just wait till they're about 18, maybe leaving school, that group. And then there's the more acquired group where they're a little bit older, and they just age in a certain way that creates a bag and a very firm trough underneath the bag.
Right. So tell us about what you do with that tear trough ligament in surgery. I mean, how do you detach? You literally detach it.
It's detached. So I go a transconjunctival approach. So the patient's.
So this is what I was referring to earlier. The approach that he goes with, and that most of us go with, is transconjunctival, and that's on the inside of the eyelid. That's a less visible type of approach, because you don't have a scar on the outside, and it's less likely to cause what's called ectropion, where the lower eyelid actually droops down after surgery, and that's more likely with the external approach, or the subciliary approach.
Always asleep, my assistant's retracting the eyelid forward, gone through the conjunctiva, through the retractor, down to the periosteum, so I'm literally looking at the periosteum, and then I'll either incise it directly with a sharp edge of a freer periosteal elevator, or even with a diathermy, just to get onto the bone. Certainly that's a robust way to lift that area, and to, as we heard earlier about the anatomy, to elevate the attachment, one of the attachments of that ligament.
I mean, it when you say, even just saying those words, it makes me think back on all those patients I've done where we're trying to lift this tear trough, hollow, with filler, and they've got literally this tear trough attached to bone, which is attached then to their skin, and here we are trying to lift it up with a very sort of soft filler, and that's probably one of the reasons why we've had so many issues. In conclusion, given the potential longevity of hyaluronic acid fillers, the risk of inadvertent injection of filler under the eyeball, and the anatomical basis for the presence of the tear trough, the use of filler in the tear trough needs to be questioned. Filler injected into the tear trough commonly results in complications and regret. As doctors, we take on board the Hippocratic Oath, which is first, do no harm. And given the likelihood of potential problems that tear trough filler can cause, we must consider our oath in this situation. I hope the lesson that took me 14 years to learn and abduction in this video will have a positive effect in helping to educate people out there.
So again, I applaud Dr. Chan for coming out there and speaking his mind, interviewing some wonderful experts in the field. I think it's good to take a step back from all of the surgeries and non-surgeries, non-surgical procedures that we do, especially on the face and the whole body. I mean, there are people getting certain types of surgeries, body surgeries that are risky, like BBL, and so at what point do the risks outweigh the benefits? At what point does the doctor offer it versus not offer it because it's too risky? Do we just let patients decide what they want, or do we step in and say, I'm not going to offer this to you anymore? All really interesting questions, and I definitely would like to see the community take this style of approach to hair surgery, to facial plastic surgery, because that's what's near and dear to my heart, and also for the non-surgical procedures as well, and really assess. And this also goes for a lot of the devices that are being used. It's not just about injectables or surgery, it's about all these non-surgical devices that are used on the face, whether it be radiofrequency, laser resurfacing, microneedling, other types of devices that are meant to rebuild collagen by actually promoting some degree of scar tissue, and how effective they are and how dangerous they are. Althera, a lot of different things that were popular at one point and then lose their popularity as people get dissatisfied with the results, and as people start to discover that there are real complications that occur from these non-surgical things. Great discussion here. Really enjoyed Dr. Chan's video, and hopefully you guys enjoyed some of this commentary. Again, please make sure to like, comment, subscribe, turn on the notifications. We have a lot more of these videos coming. It's always nice to react to a really well done video. It makes it more enjoyable for me. So hopefully you guys enjoy this and learn something. Take care.